This is our chapter on neuroimaging and stereotactic functional neurosurgery by Harith Akram and Ludwig Zrinzer. The objectives are to demonstrate that neuroimaging is a key component of safe and effective stereotactic intervention, to demonstrate that dedicated structural MRI sequences can be used to visualize individual patient anatomy and therefore more effectively guide surgical targeting, to show how MRI connectivity may be used to target structures that cannot be seen on traditional stereotactic structural MRI scans. We will also explain how stereotactic imaging is essential, either using MRI or CT, in confirming accurate anatomical targeting during the functional neurosurgery procedure, therefore confirming the accuracy of surgical targeting. Finally, functional neurosurgeons need to understand the potential pitfalls of neuroimaging techniques if they are to avoid them, and therefore maximize the potential of stereotactic imaging when trying to benefit their patients. Functional neurosurgery depends on the stereotactic technique developed by Horsley and Clark in the early 1900s in London. Functional neurosurgery is an acute anatomical intervention with the aim of providing a positive chronic change in function in patients with neurological conditions such as movement disorders, epilepsy, or mental disorders, with the ultimate aim in improving quality of life. And of course, this demands minimal risk of morbidity and mortality. The principles of the stereotactic technique will be covered in other chapters. However, the principles are very similar to that of placing a grid over a map, whereby we allow mathematical calculation of precise coordinates within the living human brain. Early stereotactic surgeons were hindered by the inability to visualize living structures within the human brain, and they therefore came up with very inventive ways of trying to bypass or overcome these limitations. Chief among them was indirect targeting, where ventriculography enabled surgeons to visualize the location of the anterior and posterior commissures within stereotactic space within the individual patient they were operating upon. And they then relied on stereotactic atlases that provided them with coordinates of where these structures are likely to lie in relation to these internal landmarks. But of course, there was always a degree of variability, and therefore during surgery, multiple tracks had to be passed through the brain, and there had to be indirect confirmation of where the intervention was taking place, either by looking at clinical factors with reversible lesions and testing the symptoms or any other signs that might be elicited, as well as developing surrogate electrophysiological markers such as microelectrode recording by recognizing patterns of neuronal firing that give one an idea of where the tip of the probe is at that point in time. However, when MRI was developed and made its way to clinical practice, this became a real game changer when it came to stereotactic surgery, because it allows neurosurgeons to visualize the patient-specific anatomy in the patient on the operating table. And Lars Lexell was one of the first neurosurgeons to understand the importance of this, and he realized that when it came to diagnostics, it was the responsibility of the radiologist to understand the imaging techniques that were being used. But when it came to stereotactic intervention, with the images being used to guide the accuracy of the surgical intervention, this then became the surgeon's responsibility, and it has to be integrated with the operation in terms of understanding the nuances of the neuroimaging techniques being put to use. One development from this is the development of the MRI-guided and MRI-verified approach. MRI is a very powerful tool given its accuracy, speed and non-invasive nature of demonstrating neuroanatomy with great resolution and great detail. And we can use stereotactic MRI both to guide the DBS implantation or the surgical intervention, but also to verify that the surgical intervention has occurred at the predetermined spot, or to determine that the lead has been implanted at the desired point. One of the main advantages of using dedicated stereotactic MR sequences is that one can select a sequence that allows the structure that is being targeted to be visualized. And here we can see T2 weighted imaging showing us the subthalamic nucleus anterolateral to the red nucleus. And we can see that there is variability between one patient and another, not only in terms of the location of the structure, but also the orientation of the structure in three-dimensional space. The same is true of this proton density weighted imaging at 1.5 Tesla, where you can see the lentiform nucleus with gley clarity, with the putamen laterally, and the various segments of the globus pallidus medially, even the accessory lamina within the globus pallidus pars interna, as well as the medial medullary and lateral medullary lamina. And here we can see the variability in anatomy with a patient with a very wide biparietal diameter at the top and a much narrower scaphocephalic head towards the bottom. And what this enables us to do is that if we were to use atlas coordinates in the first patient, we would be targeting the posterior limb of the internal capsule rather than the posteroventral pallidum as desired. The converse is true in the inferior image, where we would be targeting the lateral part of the pallidum, or even lateral to that, if we were to use atlas coordinates. So the variability of these anatomical structures is highlighted by these two examples, and the importance of using different sequences when targeting different structures is also highlighted here. When using MR to guide surgical approaches, it's very important to understand the pitfalls. One of them is the fact that MR images are often distorted, and because this distortion does not interfere with diagnostic capabilities, radiologists often ignore this or do not consider it. But you can see very clearly in this example on the slide that prior to applying the distortion algorithm that's present on many MR scanners, there is a huge degree of distortion of the fiducial plates surrounding the head in this stereotactic procedure. And by applying this algorithm, which takes only a few seconds, there is a huge improvement in the distortion, as you can see on the right-hand image. In the 1990s, there was a movement to try and address this distortion by fusing MRI scans with non-distorted stereotactic CT scans, but surgeons often fail to appreciate the degree of distortion, because if you're obtaining a non-stereotactic MR, you cannot see the degree of distortion of the images. And clearly this is a non-linear distortion, and therefore a linear transformation of an MR image being co-registered to a CT will fail miserably at correcting that type of distortion. So there's a very important point if you're going to maximize the use of your imaging to guide your initial approach. And if you do not make corrections, if you don't know these pitfalls, you'll pay the price by having to make further tracks during surgery, and possibly using surrogate markers to tell you where you are. Traditional structural MR sequences can now be supplemented by advanced imaging techniques, by which we mean computational neuroimaging, where one can use parametric imaging to obtain very detailed structural nuances, where one can use functional imaging such as fMRI or PET to understand how different areas of the brain fire, or rather are overactive in various pathologies. This example is in cluster headache, where the ventral tegmental area or posterior hypothalamus is known to be overactive in cluster headache attacks, and this can guide surgeons to potential new targets within the field. Additionally, one can use MR connectivity, either using structural connectivity with diffusion-weighted imaging or looking at fMRI synchrony between various areas to see how various areas of the brain are and train each other to understand the individual connectivity in particular patients or patient groups. Taking one example here, the motor thalamus or the ventral intermediate nucleus is a commonly used target for patients with tremor. However, none of the sequences at 1.5 or 3 Tesla reliably show us the structure location of the ventral intermediate nucleus. And one approach that is being tried to overcome this is to use diffusion-weighted imaging and probabilistic connectivity to define the region of the thalamus that is most likely to be connected to the ipsilateral motor cortex and the contralateral dentate nucleus. And if we look at these probabilistic maps, you can see here the crossing of the dentator-thalamic fibers, as well as the motor fibers between the thalamus and the primary motor cortex. And where these areas overlap is the motor thalamus as defined by connectivity. And here we can see a patient with essential tremor who has very bad handwriting prior to surgery, and the ventral intermediate nucleus was localized using these techniques with connectivity imaging, and you can see the great improvement after a thalamotomy that was guided by probabilistic MR connectivity. One of the problems with this approach is that this is a very technically challenging field to work in, with significant pitfalls for the non-initiated. You require significant computational needs because putting the data of probabilistic imaging through computer networks can take hours, if not days, unless one has the right equipment. And this approach, it has to be said, still requires clinical validation as to its superiority over more traditional targeting techniques, but the early results look very promising. As an example, this is a lady with a cavernoma straddling the brainstem and thalamus, and she presents with Holmes tremor in the video. And what we can see here is when the motor thalamus is defined by dint of its connectivity, you can see that there's a huge asymmetry between the VIM or the motor thalamus, and it would have been rather difficult to target the thalamus to help tremor without connectivity being present. And here we can see the severity of the tremor. So the cavernoma is in the left side of the brain, and she has Holmes tremor on the right. And one of her main wishes was to be able to hold her grandson, and she was unable to do this because of the severity of tremor. She needed help to get pen to paper to test her handwriting prior to surgery. We still did the surgery awake despite the connectivity guided approach, because the patient selected to have a thalamotomy rather than DBS for this procedure. And one can see that after introduction of the probe and a small thalamotomy, there's a huge improvement in the tremor with great functional benefit, much more control, and a great improvement in the handwriting from pre-surgery to post-surgery. So the image verified approach is another way of using imaging to help functional neurosurgeons. And it is very important not only to use imaging to guide the surgeon to the anatomical target in question, but also to use imaging to actually confirm where the intervention has taken place. And stereotactic MRI is the gold standard when using sequences that allow visualization of the relevant anatomy, because this allows you to see where your intervention is in relation to the target, to the structure being targeted. Moreover, if you're performing DBS, deep brain stimulation, and the lead is suboptimally placed, because the frame is still on the head, it's a stereotactic sequence, This allows immediate relocation of the suboptimally placed DBS lead. And this is an important thing because sometimes the clinical improvement can be excellent during surgery despite a suboptimally placed leads, but we know that a suboptimal lead in the long run will not have a good clinical outcome as a lead that is optimally anatomically placed. A number of centres use stereotactic CT or X-ray, and this is a good silver standard. One of the problems is that you cannot visualise the relevant anatomy. However, if there is very little brain shift, you can define the stereotactic coordinates of your intervention, and therefore you can compare the accuracy, or you can analyse the accuracy of your intervention. However, if there is significant brain shift, stereotactic MRI clearly has the edge there by being able to see the shift of the patient's anatomy as well. If there is not a significant degree of brain shift and you have suboptimally placed leads, stereotactic CT or X-ray can allow you to re-implant during the same procedure. Conversely, if you're performing an MRI once the frame has been removed, well, if you're in the right place, that's all fine and dandy, but if you're not, you do not have the opportunity of relocating those leads without submitting the patient to a further intervention. And the same is true of stereotactic CT or X-ray, but on top of that, it's more difficult to ascertain the exact location of the DBS contacts or the surgical intervention because you cannot you require fusion of your MRI with your stereotactic, with your CT or X-ray, and that can be quite tricky and introducing errors. So this is what this would look like. You can see very clearly the fiducial markers, in this case of the Lexel frame, surrounding this patient's head, and you can see the artifact generated by the deep brain stimulation leads within the subthalamic nucleus on either side. And this is just to illustrate the anatomy of the red nucleus and the subthalamic nucleus. And a few of the advantages of this is that you avoid co-registering images, and therefore you avoid any fusion errors when assessing lead location. This allows you to directly visualize the DBS lead in relation to the anatomical target and provides the most accurate assessment of anatomical location of each contact. We've already discussed the importance of allowing us to relocate suboptimal leads when necessary. And this is not an uncommon factor. We know that thousands of patients undergo surgery every year in the United States because of suboptimally placed leads in the first procedure, and therefore not only do we need to be accurate, but we also need to be precise, and individual patients we need to be both accurate and precise in terms of the degree of veracity in relation to the intended target, as well as the degree of reproducibility. The only way to improve our accuracy and precision is to actually audit our accuracy and precision. And it would be very difficult to audit this without some sort of stereotactic imaging during the procedure that allows us to compare the intended stereotactic coordinates with the actual stereotactic coordinates of the intervention. One problem that is often raised is whether it is safe to perform MRI scans in patients with implanted deep brain stimulation hardware, and there are real valid reasons to question this because there are interactions between both the static and the gradient magnetic fields, as well as the radio frequency fields generated during an MRI scan. The potential problems could include heating, movements, generation of current, as well as interference with the pacemaker function. However, the truth is, the clinical experience is that thousands of MRI exams with DBS hardware have been published in the literature without adverse events. And there have only been a handful of adverse events, mainly when precautions haven't been followed. And there's only one case of permanent neurological deficit when there were major deviations from the recommendations. So it's really important to realise that a lot of the hardware that's available commercially for deep brain stimulation procedures is now MR conditional, and that means that the risk is exceedingly low when proper precautions are followed, when one is following the manufacturer's guidelines, but also limiting the amount of energy delivered during a scan, and this can be estimated using what is called the specific absorption rate, the SAR, which is the amount of energy in watts per kilo, or more recently another measure, the B1 plus RMS, has been introduced, which is actually more accurate in terms of assessing safety. It's very important that there is no breakage in the hardware prior to the scan, therefore impedance checks are really quite important, and you want to prevent patient movement during the MRI scan. There are a number of other precautions that one should take, but one should not give a blanket no MRI for patients with MR conditional hardware implanted. Of course, the importance of neuroimaging in functional neurosurgery is highlighted by gamma knife thalamotomy and the more recently introduced MR-guided focused ultrasound, where there's complete reliance on MR imaging in terms of the intervention being performed without the possibility of obtaining surrogate physiological markers. Certainly in MR-guided focused ultrasound, one can use the clinical feedback from the patient when performing surgery for tremor, but I will leave a more detailed discussion of both of these techniques to the authors of other chapters. It's important to say that MR imaging is continually improving, and here we see a space sequence at 3 Tesla, which took a little over 10 minutes to obtain, and the degree of clarity that one can see the subthalamic nucleus and the red nucleus is quite amazing. And this is a slide showing an MR of a cadaver specimen at 9.4 Tesla with almost histological detail. And of course there are a number of clinical scanners in between these, with 7 Tesla scanners becoming more common. Suffice to say that neuroimaging is advancing at a great pace, and it's not just about the strength of the scanner field, but it's also about the coils that are used and the imaging sequences that are selected for a particular target, while keeping in mind not only image contrast and resolution, but also distortion, because this is very important in terms of surgical targeting. And functional neurosurgeons should capitalize on these improvements in imaging. So to summarize, the potential use of imaging in functional neurosurgery traditionally depends on direct targeting by visualizing the structures and then verifying that the target has been reached by performing a stereotactic image. And therefore that allows us to audit our results to improve accuracy and precision, but also to test where the intervention was together and compare with the efficacy and side effects, not only acutely after surgery, but even many years following surgery, to try and optimize our targeting technique and minimize side effects and improve efficacy over the years. So there's this audit loop of how we can use imaging to improve outcome in functional neurosurgery patients. When it comes to the more advanced imaging techniques, we've already discussed connectivity-derived segmentation to target structures that we cannot see using traditional structural MR sequences. But there are also moves to try and see whether we can use functional imaging or connectivity imaging to predict as predictive biomarkers of response in individual patients or patient groups, performing mechanistic studies to try and analyze the mechanisms by which disease occurs, but also by which how our treatments improve symptoms, as well as guiding us to potential new targets. And there are some examples in the chapter of where this has been attempted with conditions such as cluster headache or even major depression. And to summarize, one really has to choose the most appropriate tools for the job, and clearly stereotactic MRI is the gold standard when visualizing targets in functional neurosurgery, but also when confirming or analyzing the surgical intervention that's being performed. The benefits of MRI verified surgery include improved patient comfort and safety, because you minimize the number of tracks, and very often surgery can be performed under general anesthesia. And this is accompanied by a reduction in surgical time and cost. It's important to realize that MRI can be performed safely with implanted DBS leads. However, certain precautions must be observed, and the MR physicist and neuroradiology department are very much part of the multidisciplinary team that forms the functional neurosurgical practice. Image-guided and image-verified stereotactic surgery is not a shortcut. It requires a very meticulous approach and careful audit to get the best results. And as MR imaging continues to improve, functional neurosurgeons must remain familiar with the nuances of the imaging techniques if they're going to avoid the potential